For centuries, what people called madness stayed frighteningly unclear. A person might swing from despair to rage, speak in confusion, or stop responding at all, and no one agreed why. Physicians still reached for the best map they had, the ancient idea of humours. Health, they believed, depended on balance. When the mind broke, the body had to be out of order too. In that framework, thoughts and feelings did not float free in the brain. They rose from blood, bile, and other fluids moving wrongly through the body. Too much heat, too much cold, too much thickness, too much stagnation, any of it could tilt a person into terror or frenzy. The cause sounded physical, so the cure sounded physical. Restore flow, force balance, make the excess leave. That belief pointed doctors toward harsh, dramatic actions. If illness came from dangerous build-up, then strong purging promised relief. Bleeding, blistering, emetics, and violent laxatives all aimed at the same goal: drive something out, and the mind might settle. Suffering became part of the logic. The more powerful the bodily reaction, the more convincing it looked as medicine, and that made extreme methods feel reasonable. Then a new idea arrived that sounded practical, almost mechanical. If the body could be pushed hard enough, the mind might follow. Doctors proposed a rotating chair built to spin a person in place on command. Motion itself became the medicine. The promise was simple. Spinning disturbed the senses, scrambled balance, and forced the body into a crisis it had to correct. Order, they believed, could be jolted back into the patient. The logic rested on a blunt assumption. Mental disorder reflected a body that had slipped out of regulation. Rotation looked like a way to intervene without knives or drugs. It acted fast. A patient who felt steady a moment earlier became dizzy, then overwhelmed, then unable to keep thoughts or posture organized. For physicians, that collapse mattered. They expected the nervous system to reset afterward, as if shock could break a harmful pattern and restart normal function. Once the chair existed, it changed what treatment could mean. Care no longer required long observation or slow adjustment. It could be delivered in a burst. The spinning could be measured, repeated, increased. That made it attractive to doctors who wanted something they could control and report. And it offered a visible effect that looked like action. The patient spun, the body reacted, and the physician could claim the intervention had reached the mind through the body. Once the rotating chair entered practice, it stopped being an experiment and became something doctors actually prescribed. They matched it to the labels they used at the time. Melancholic for deep sadness and withdrawal, manic for agitation and racing behavior, delirious for confusion and restlessness. The logic sounded simple. If the mind looked stuck or overheated, motion might unsettle it, then push it back into order. In case notes, physicians treated the chair like any other intervention: a set time, a set pace, and a watched reaction. Patients were spun until their faces changed, their eyes lost focus, and their bodies showed clear dizziness. That response mattered. It served as proof that the body had been strongly affected, and if the body shifted, the mind might follow. This was not entertainment. It was medicine by force. Each use made the next use easier to justify. When a patient grew quieter afterward, even briefly, the chair earned credit. When someone seemed worse, the answer often became more control and another attempt, not less. The treatment settled into routine. Agitation met rotation. Withdrawal met rotation. Confusion met rotation. Spinning to the edge of collapse became an accepted clinical step, not a strange curiosity. Once the rotating chair felt accepted, some practitioners pushed it further. They did not stop at dizziness. They chased a stronger reaction, turning the chair faster and keeping it going longer. The goal shifted from simply unsettling the senses to forcing the stomach to turn. Nausea became the target. Patients clung on, then lost control as the body tried to protect itself. When vomiting came, it did not count as a warning sign. It counted as proof. In their notes and explanations, sickness meant the treatment had reached the right intensity. If nothing happened, the dose of spinning seemed too small, and the answer became more rotation. The logic fed itself. The worse the reaction, the more convincing the method appeared to the people running it. This escalation changed the chair from a test into an ordeal. It trained staff to look for visible, undeniable results, even when those results were simply the body in distress. Vomit, sweating, collapse and trembling were read as the system emptying something harmful. The patient's suffering became a measurement tool, and with that, the line between therapy and punishment grew thinner with every turn. Once the chair looked like it produced results, the idea stopped living in one doctor's hands. It travelled. Physicians wrote up cases in medical journals and sent letters describing what they saw, step by step, as if the method needed only the right instructions. Then came demonstrations, where visitors watched the same pattern repeat. A technique that had felt experimental now looked teachable. And teachable meant transferable. Hospitals and asylums adopted it because it fit their needs. It was fast. It required no rare drug and no delicate skill once the chair existed. Staff could apply it on schedule, record the reaction, and present the outcome as a clinical fact. Dizziness, retching, and vomiting became the measurable signs that the body had been forced to respond. In institutions built around routine, that kind of predictability carried weight. With every report, the chair gained a new kind of authority. Administrators could point to printed successes, and doctors could cite other doctors, building a chain of credibility that did not depend on any single patient improving. The chair turned into a recognizable tool of institutional psychiatry, mentioned alongside other standard interventions. It stopped being a strange experiment and became part of the system. That shift changed who got spun and how often. After the rotating chair spread, the claims started to collide with reality. Some patients seemed calmer afterward, but others returned to the same agitation within hours. A few showed no change at all. The same procedure, the same setting, and wildly different results. That inconsistency planted doubt. If this was a true cure, it should have behaved like one. Instead, it looked unpredictable. Then came the injuries. Rapid spinning did not only bring nausea, it sometimes brought collapse. Patients fainted, struck their heads, or left the chair with lasting weakness and confusion. What had been described as a controlled reset started to resemble a physical assault on the body. Staff had to restrain people who fought the chair, and restraint itself became part of the outcome. Harm was no longer an exception people could ignore. That was when the argument shifted. Supporters pointed to quiet wards and short-term obedience as proof the method worked. Critics looked at the same silence and saw something else. Exhaustion, fear, and a body overwhelmed into stillness. The question became hard to avoid. Did the chair restore a disturbed mind, or did it simply overpower it? With uneven results and visible damage, confidence started to crack. By the time the rotating chair became familiar inside institutions, a different kind of pressure built from the outside. Reformers looked at overcrowded asylums and argued that people did not improve from fear and force. A new idea gained ground. Structured daily life could calm distress. Instead of treating madness like a problem to purge out of the body, care started to emphasize routine, rest, work, and steady contact with others. This approach became known as moral treatment. It did not mean sermons or punishment. It meant order, predictability, and basic respect, with staff expected to watch, guide, and de-escalate rather than overwhelm. When that logic entered an asylum, the spinning chair looked different. It no longer seemed like a neutral medical tool. It seemed like a shortcut, an extreme method that produced obedience, not recovery. So, the chair drifted from routine use to selective use. Some doctors defended it as a last resort for dangerous agitation, claiming quick control prevented worse harm. Others treated it as a symbol of the old regime, tied to coercion and shaky results. The debate shifted the ground beneath the practice. The rotating chair did not vanish overnight, but it stopped feeling inevitable. It became contested, questioned, and easier to abandon. By the mid-1800s, medicine started explaining the mind in a different language. The nervous system became the focus, not bad fluids that needed forcing out. Doctors mapped reflexes, brain injuries, and seizures, and mental illness looked less like a blockage to purge and more like a condition to study. That change mattered. If the problem lived in nerves and brain, spinning until vomiting sounded less like science and more like guesswork. New tools followed that shift. Sedatives and anesthetics entered practice, and later specific psychiatric drugs appeared, offering calmer, more predictable effects than shock. Hospitals also began separating, quieting someone down from actually treating them. Observation became a method, not an afterthought. Case notes tracked sleep, appetite, speech, and relapse over time. When results could be compared, the spinning chair struggled. It produced dramatic reactions, but it rarely produced reliable recovery. As psychiatry organized itself as a modern field, it increasingly demanded explanations, not just control. Clinics favored approaches that could be repeated with fewer injuries and clearer outcomes. The rotating chair still existed, but it no longer fit the direction of care. It belonged to an older logic: provoke a crisis, claim the crisis proved cure. That logic faded. In everyday practice, the chair slipped out of treatment rooms and into the record books. The rotating chair did not vanish into success. It lingered as a warning. Later generations looked back and saw how easily a medical tool became a symbol of certainty without proof. The logic had sounded clean at the time: make the body react and the mind would follow. But the lasting record showed something else. It showed how suffering had been mistaken for progress. Modern ethics reframed the chair in a harsher light. Consent mattered, and many patients never truly had it. When spinning became something done to a person, not with a person, treatment turned into control. The same action could calm a ward, end a struggle, or silence distress, and it could still be written down as care. Power filled the gap where evidence had been thin. With better science, the old claims looked smaller and the harms looked bigger. Vomiting no longer read as healing, it read as a predictable reaction to force. The chair became a lesson about limits, limited knowledge, limited tools, and institutions that could confuse order with recovery. Remembered this way, it did not represent progress. It represented what happened when authority outran understanding. In modern psychiatry, treatment did not rely on making a person collapse, retch, or faint to prove anything. It relied on evidence. Doctors tracked whether symptoms eased over time, whether daily life improved, and whether harm appeared along the way. That shift changed the whole logic of care. Vomiting stopped being interpreted as success. It became a warning sign. The goal moved from provoking dramatic reactions to producing stable, measurable recovery. That new logic brought rules. Treatments became standardized, studied, and adjusted when they failed. Medicines came with known risks, dose ranges and monitoring, not just bravado and speed. Psychotherapy became structured and tested, not improvised authority. Hospitals followed protocols and oversight bodies checked safety. When restraint or emergency sedation happened, it required documentation and clear criteria. The rotating chair belonged to a world where proof meant spectacle, not outcomes. Just as important, patients gained rights. Consent, privacy, and the ability to refuse or appeal treatment became central, not optional. Involuntary care still existed, but it required legal safeguards and regular review because harm had to count. That principle cut against the old certainty that suffering itself was therapeutic. The story of spinning until vomiting ended up marking a turning point. Medicine stopped chasing forced symptoms and started measuring real change.